This is part 3, and we are demonstrating an image, and this is taken from one of the research studies in which they applied a belt with force transducers to measure the amount of force within the joints, and they applied it at 3 levels. This is level 1, which is right at the trochanters of the hip, and then level 2 is an intermediate position here, and then position number 3 is rather high up. And I'm going to read the text here. These 3 levels were evaluated with force transducers to determine the optimal placement of pelvic binder. Level 1 at the trochanters is superior, meaning more beneficial, to levels 2 and 3, which are higher up. And now I will show you image 6 and 7. So in image 6, this is a typical location for application of a sacroiliac support. And a little arrow there, and belly button is probably right about there. And then in image 7 here, it shows the optimal trochanteric location, a little bit about mid-level of the front pockets, considerably lower from the belly button. And the text reads, "This is the optimal trochanter location for pelvic belt application, for pubic joint dysfunction, and especially for traumatic symphyseal diastasis, and also for obstetric pubic symphyseal diastasis." In physical therapy and rehabilitation literature, placement is not usually specifically reported, and studies are inconclusive. Because the support typically is referred to as a sacroiliac joint support, the nomenclature implies placement at the level of the sacroiliac joint, just below the waist, above the trochanters. There actually is a support named a trochanter belt, but I would say that the marketing for sacroiliac supports greatly exceeds that of marketing for trochanter belts. In addition, much of the advertising for various sacroiliac joint supports advocates the higher placement without acknowledging the possibility of primary pubic joint dysfunction or primary obstetric pubic symphyseal diastasis. Placing the support at the trochanters is superior regarding biomechanics and amount of therapeutic force for these kinds of dysfunction. Studies with cadavers using force transducers validates that up to 40% more compression occurs in the pelvic joints, meaning the sacroiliac joints and especially the pubic joints, and the force is directly in line with the pubic joints. And we've already shown those images. A more comfortable application using less pressure, yet receiving greater compression, is accomplished. The typical higher sacroiliac joint application at the level of the waist or just slightly below the waist actually replicates joint laxity of pregnancy and birth. So if we use the pelvic model here, and if we were to apply circumferential support here, you can see that very similarly the primary compression occurs in the upper pubic joint and in the upper SI joint. So wearing it high actually replicates to a degree the laxity related to pregnancy and delivery. Now, this does not negate the value of higher placement in a specific population. What I mean by that is that there are people who actually benefit with a higher application, and that has been studied in a population of people who had primary sacroiliac joint dysfunction. It gets a little bit complicated too, because different people have different shapes of joints, and so that leads to my next statement, which is, this does not negate the value of higher placement in specific populations, hence the need for experimentation over dogmatism. In other words, while we have research that indicates that you should apply it much lower for identified cases of pubic joint hypermobility or instability, there are times when we don't know there is a wide gray area, and applying it at different locations will indicate the most optimal placement. And if the client is comfortable with the belt on, they're going to tend to be more compliant, and I trust that the location that is most comfortable is in fact the most ideal one. There is some belief that a trochanter belt will ride up when people sit and so on, and that simply is not true. If you find an appropriate support that is ideally wide, and they make some that even taper, if it fits comfortably, it should not ride up when they sit. It is hoped that educated patients and informed clinicians will increasingly promote the test and retest pelvic support placement at any of the 3 different levels for primary pubic joint dysfunction or mild to severe obstetric pubic symphyseal diastasis. Conclusion. The orthopedic trauma research enhances orthopedic manual physical therapists and women's health physical therapists and other hands-on professionals' understanding of pubic joint dysfunction, of traumatic symphyseal diastasis, and of obstetric pubic symphyseal diastasis. Ideally, improved early diagnosis and intervention for pubic joint dysfunction and for non-surgical obstetric pubic symphyseal diastasis may facilitate successful early rehabilitation. Additionally, hands-on stress testing or spring testing may conceivably identify cases of occult instability. Novel interpretation of biomechanics based on the literature, based on images from the literature, may predict novel interpretation and novel intervention. Mobility and stability testing is worthy of exploration in the chronic pubic joint dysfunction and the chronic obstetric and traumatic pubic symphyseal diastasis populations. This theory seems promising, and clinical research is needed to determine if this model has clinical validity and utility. Orthopedic manual physical therapists, women health physical therapists, and other hands-on clinicians may have much to offer to the non-surgical population who suffer from pubic joint dysfunction and traumatic and obstetric pubic symphyseal diastasis. This has been a presentation on a poster titled Pubic Joint Dysfunction and Symphyseal Diastasis, a novel biomechanical model. This was presented by Jerry Hesch from the Hesch Institute in Henderson, Nevada, very close to Las Vegas. It was a poster presentation at the American Academy of Orthopedic Manual Physical Therapy Conference, October 18, 2013 in Cincinnati, Ohio. And again, it was presented by the Hesch Institute, and we have a clinic close to Las Vegas, Nevada, and Henderson, Nevada. Our website is www.heschinstitute.com. That is H-E-S like Sam, C-H, institute.com. And this is the entire poster, and thank you very much.